Good morning and welcome to this session on improving care for pregnant and postpartum women with opioid use disorder. This webinar has been organized by the MD Mom Program, a 5-year statewide maternal health program in Maryland, funded through the Health Resources and Services Administration's Maternal Health Innovation Grants. My name is Jennifer Callahan-Coru. I'm an assistant professor of public health at the University of Maryland, Baltimore County, and I am also a member of the MD Mom program team that is organizing this webinar. I'll be giving an overview of the program and helping us transition between speakers this morning. Today's webinar will include presentations from experts on obstetric care for women with opioid use disorder and from hospital teams in Maryland. The objective of today's program is to disseminate information on existing tools and best practices in obstetric care for women with opioid use disorder. In a following workshop, stakeholders in Maryland will discuss approaches and tools that can be incorporated into state programs to improve the quality of care for pregnant and postpartum women with opioid use disorder. The agenda for the webinar is presented here. We'll hear from 3 expert speakers from other states, Dr. Mishka Turplin, Dr. Ronald Iverson, and Dr. Ann Borders. Then we'll hear from leaders at Maryland hospitals who have been engaged in this work, Kendra Ellison from Baltimore Washington Medical Center, and Dr. Michelle Musgrave from Sinai Hospital in Baltimore City. I'd like to note that in addition to the listed speakers, we have a wonderful group of participants from within Maryland, representing hospitals from across the state, the Department of Health and state Medicaid programs, county behavioral health services, as well as representatives from HRSA and the National Alliance for Innovation in Maternal Health program. We are looking forward to their questions and contributions during the workshop. Now I'd like to welcome our first speaker, Dr. Mishka Turplin. Mishka is a physician who is board certified in both obstetrics and gynecology, as well as addiction medicine. He was involved in the development of clinical guidelines for pregnant and postpartum women with substance use disorder, and he will be providing us with an overview of developments in this area. Please go ahead, Mishka.
Great, thank you. Thanks so much for inviting me and having me here. Just go to the next slide. So I really wanted to I was asked to review the initiatives, mostly sort of federal-ish or national, around improving obstetric care for women with substance use disorder. And I want to do really 2 things. The first is sort of ground this in a couple of principles to keep in mind as I think you move through the day, some of which are obvious. And 2, do what I was asked, and it's going to be selective because there's been so much real attention and so many different initiatives and et cetera. So clearly, when we're talking about addiction, we want the care to be grounded in addiction science and also care grounded or at least reflective of the evidence base. Can you go to the next slide, which we'll talk about as we go through this. The other 2 principles is, one, when there's something artificial about saying, substance use disorder in pregnancy, because addiction does not arise de novo in pregnancy. Addiction is not a condition of pregnancy. It's really what we're talking about is where, the addiction life course, use to misuse to the development of use disorder intersects with a reproductive health life course, getting pregnant, staying pregnant, and delivering a baby. And so I want, as you think about programming and planning, it really needs to be not just focused on the gestational period, but inclusive, reflecting the life course and inclusive of both postpartum and sort of prepartum, i.e. reproductive health life planning. And from a care perspective, this really means moving, I think, from specialist to holist, and from individual delivery of care to team, based delivery services. Next slide. And the second thing too is to think about care is not just, and this is where care in pregnancy is, it's the dyad It's not just, it's beyond the individuals, thinking about the family, the child, the community, and really how is what you're talking about, how does that, is that placed within, SAMHSA's, working definition of recovery, which is here on this slide, and thinking about with how it sits within recovery-oriented systems of care. So next slide. So I thought I would frame this around something that maybe some of you know, but maybe some of you, and certainly I think some of you don't. And this is something that's called the Women's Action Group. It's a group of that emerged out of American Society of Addiction Medicine almost like 10 years ago. And this is the mission statement that we wrote way back then. And it's really a group of people somewhat affiliated with ASAM who care for what I've always wanted the group to be is more about gender and addiction, but it's always keeps sort of drifting into pregnancy and addiction. And the group has grown incredibly. There's a good now like 150 different people who are somewhat active on the listserv. And in January of this year, we actually had the first in-person conference on pregnancy addiction, or gender and addiction, and et cetera. And I mention this group because I think because one, this is like the history of this group to some extent is the history of my involvement in this topical area. And it's also how some of the initiatives happened and continue to happen. So the next slide. So one of the first things that we did was, we were asked by Acog to update the committee opinion on addiction. And this was, I think, really this became one of the first sort of modern era guideline, although it's still not that modern in terms, as you can see, of the language. And in this, really like our little team wrote this, and then it, got approved through, the powers that be. This collaboration between Acog and ASAM has lapsed a little bit recently. I think as this field has grown a touch, there's been a divergence at the professional society level. So next slide. And you can see that this is, and then one after this too, next slide. These are the ASAM then and Acog each individually updated this guideline. And the next slide, and even though ASAM signed on to the Acog one, Acog did not sign on to the ASAM one. These are professional society recommendations. These are the level of evidence is expert opinion, which has to then be navigated through the board of directors that votes on this to okay it. I will say that these documents, in a particular the Acog one, overemphasize screening, somewhat emphasize brief interventions, and don't emphasize treatment as much. And over time, there's been an increased sort of inclusion of detoxification as a treatment modality. Next slide. So in contrast to professional society recommendations, here on the left is a very important document from the World Health Organization that Andrea, who's part of this group, participated in actively. And on the right-hand side is the SAMHSA clinical guidance. So next slide. And these are, the level of evidence is different. The WHO has a very rigorous system for evidence assessment, and SAMHSA guidance document, was used this sort of RAND UCLA appropriateness method, the RAM method, for determination. So it's really approaches the level of evidence of a systematic review. Next slide. And I think that the importance of these is that they more than the professional society recommendations address stigma or discrimination. They're person-centered, and SAMHSA in particular is quite usable. It's organized into handouts. It has both that are useful for providers at any kind of provider at any stage of training, and also for patients. And so that is, I think these are big. Next slide. Now you're going to hear more about this in particular, from Dr. Borders, and because Illinois is really the state that I think has implemented this patient safety bundle so incredibly and inspirationally well. But this was even talking about what the level of evidence is for this is kind of doesn't even fit with how we usually think about evidence, because this was a multidisciplinary group of experts, but it was not based upon evidence evaluation. It was concrete. It's actually really grounded in expert opinion and systematic reviews, but it's really a document that should serve as an example of implementation science. It's person-centered, speaks to recovery-oriented systems of care. You can go to the next slide, but I'm going to say what I haven't said at all, what I not purposely, but with time, because of time, not discussed in this. And that is all of the initiatives that emerged out of, the federal, in particular, federal government. Andrea organized when she was at CDC, I think, the first federal meeting on opioids in particular and pregnancy. Since then, there have been meetings at, FDA, SAMHSA, NIH, NICHD, et cetera. I have not talked about those. They all, papers and whatever came out of all of those because I decided to focus on this. So really what I think the contrast is between a, professional society like guideline versus, a guidance document, which would be like the SAMHSA or the WHO. And really like guidelines, although as our professional society membership, we turn to those constantly, they reflect really a specific professional society. They're, at best a minimum set of standards, and they are actually rarely inspirational. They actually lag both evidence and practice. So for example, in the guide, both ASAM and Acog still state, buprenorphine monotherapy recommended. And that is not what practice is. That's actually not really reflective of the evidence base, and that when we did the SAMHSA guidance document, that was purposely absent. We talked about buprenorphine, not monoproduct versus combination product, to make it more streamlined and simple, which, in retrospect could have been an error. The other thing is that these, guidelines, professional societies are not maps nor strategies, and that's what the bundle is. And I would say the final point is that regardless of what you put into place, and the ASAM waiver training is a good example of this, providers actually need continued support. It's not just about getting people waivered, it's about supporting them thereafter. So with that, the next slide, which I think is the final slide, which is my contact information and also the phone line for the National Consultation Center at UCSF, which is a very good way to provide continuing support for people in the field. It's free, provider to provider phone call, it's HRSA funded, and et cetera. And with that, I'm going to stop. Thank you very much.
Thank you, Mishka. Our next presenter is Dr. Ronald Iverson, Assistant Professor of Obstetrics and Gynecology at the Boston University School of Medicine, as well as the Vice Chair of Obstetrics and Director of Labor and Delivery at Boston Medical Center. Dr. Iverson will be sharing the work of the Massachusetts Perinatal Collaborative to address opioid use disorder. Ronald, please go ahead.
Great, thank you very much. Thanks, Mishka. That was really awesome and amazing. Thank you for setting the stage for the stuff we're going to talk about now. And I want to just, next slide, please, just talk about what we've been doing here, tell our story real quickly in Massachusetts and how we've been working on helping care for women with substance use disorder in pregnancy and through the life course, along with a lot of others. Next slide. What we're going to talk about, what is a PINQUIN? That's who we are. What is just briefly, what's our data, what's our environment here, talk about who we work with, how we do our work, and just a couple of the projects. I really wanted to think about the maternal side here. We have amazing work being done by our neonatal colleagues that'll touch on that as well. But I just wanted to go through a few lessons that we've picked up over the last few years as we've done this work. Next slide. So just quickly, PINQUIN is the Perinatal Neonatal Quality Improvement Network. And our vision is, of course, to provide, make Massachusetts a state where every mother newborn receives the safest and highest quality care, regardless of income, race, ethnicity. Next, please. We're part of a, PINQUIN is really part of a sort of a group action here with DPH, Betsy Lehman Center, Health Policy Commission, March of Dimes. We've just worked with a ton of different groups here in Massachusetts with our Mass Perinatal Quality Collaborative side focusing on moms, and NeoQuick is the Neonatal Quality Improvement Collaborative working in their space as well. We really came together around opioid use disorder, recognizing that this is, the pregnancy is just part of this entire life course that Mishka was pointing out, and that we really needed each other with the NeoQuick side to provide good care to these families. So we've focused on the AIM OUD bundle in the obstetric side, and all sorts of work is going on in the neonatal side, particularly work around Eat, Sleep, Console, and helping implement that in hospitals around the state. So lesson 1, know who you are, be grateful for all your contributors, and continue to ask for help. Next slide, please. Lesson 2 is have decent data. Next slide. The Betsy Lehman Center is a state-funded group within the Board of Registration and Medicine who have access to statewide billing data, and they're key to our providing severe maternal morbidity data to our hospitals. We're able to see that data hospital-based and statewide-based, and we're giving this to AIM as well. I have here just a slide just demonstrating here what that looks like for our constituents. The 99 right there at the end is SMM 20 without transfusions, and our SMM 21 for the state is 240. If you want to get fancy, you can compare it to the hospital. We won't do that now. And then also we can look over, and if folks want to see it, they can see their own table and their own actual numerators and denominators to see where they stand. So high level data at SMM level is really key. We also have mortality information that we keep updating within the state. Next slide, please. We have OUD associated severe maternal morbidity. And if you remember on the last slide for 2018, SMM was, I think, 214 for women with opiate use disorder, noted in their billing. Their rate of SMM 21 was 326. Next slide, please. And importantly, you know, we're very concerned with equity. I didn't point that out in the initial step, but we really try to include equity conversation and thinking in everything that we promote and try to implement. And when we present the data, we'd like people to see, you know, for instance, here, this is our OUD SMM 21 with white versus non-white women in this time frame, 2016 through the first 3 quarters of 2018. And you can see the real disparity in SMM for this group of women, 225, and twice as high for women who are non-white. So pointing out things like this is really key to helping us continue to emphasize the importance of equity in all the work we do. Next slide. We also have our own data that we generate through a REDCap system where we have a form that we've developed. Lots of states have this now when we get infant-specific information that's collected when babies who are exposed to opioids are born. The hospitals fill out the form with information on the mom and the baby. And so we're able to give this information back in much more real time to the hospitals who are participating, which is most of them. And we have a few things that we measure, and this is just a few. So we look here at the use of medication-associated treatment for mothers of opiate-exposed newborns. We might see a change there at the end. Next, please. We also look at skin-to-skin care. We've been promoting that work, particularly through the Eat, Sleep, Console program. Next slide. And as well, we are trying to move our babies out of the NICU and into nursery and just in-room care, obviously. Next slide. Also working at breastfeeding and improving breastfeeding for appropriate women with opioid use disorder and substance use disorder. Next slide, please. And thinking also about the dyad and how we can help whole families here, we have looked at EI referral prior to discharge, as well as how well we're able to do continued care and referral to participation in EI for our families. Next slide. We have information on discharge with biological parents, which we feel is reflective of how well we do our prenatal care in the hospital, and will help prepare families to take their infants home in a safe manner. Next, please. Again, back to disparities. We actually are publishing our data now. We have information on medication for opioid use disorder measured for women who are Black or Hispanic. We've demonstrated that their rate of medication use is lower. This is through that other data that I was just showing you. And it probably is reflected in the SMM data that you saw at the beginning. Next, please. So the next lesson, lesson 3, is keep the door open for new partners. Next slide. We have a leadership team that meets every 2 weeks, and we've really been lucky with people throughout the state, not only individuals, specific groups, government departments, all interested in calling in every 2 weeks, talking about what's going on, collaborating on projects, and talking about our every 6-month meeting regarding opioid use disorder. So this list is fairly plastic, fairly fluid. We change it as people join in. We've been really lucky over time to get more agencies involved, as well as more family involvement, people calling in and being part of this leadership group. And they also, of course, are involved in our summits and present around the state. So people with lived experience being part of our process is really important on our leadership team. Next, please. So finally, really for us in Massachusetts, our collaborative, we have a pretty small group of people who are sort of the central to organizing the work of lots of different groups and helping hospitals collaborate with each other, helping hospitals collaborate with organizations who are there to provide service. We generate some new product ourselves, but really we see ourselves in the middle of all this amazing activity and helping people and groups come together to get work done and help our patients. So here we go. Let's next slide, please. Okay, so one of the ways we do that is through our website. We've done a lot of work on that. So of course, we're an AIM state. We love AIM. So we have the 4 R's associated. We look across the state with different data. We present that so people can use that in their own space. Next, there we go. We record all of our webinars, and we also have a special space for the Perinatal Opioid Project that people can look up resources. There's just a lot of stuff in there. I encourage you to go online and take a look. We've got a lot to share. Most recently, we've been doing work on COVID, so there's some, I'll just put a plug in for our weekly town halls that we've been doing with really excellent conversations about QI and implementation of projects during the time of COVID. Next, please. We also have monthly OUD and pregnancy webinars. This actually started a long time ago when we would just, a number of us would just be calling in centrally to ourselves in Pinquin and collaborating. As we became an AIM state and we formalized our work, we've begun monthly webinars that involve a fair amount of collaborative conversation, successes, failures, asking for help. We always provide 15 minutes on a QI topic, and we have a curriculum that's staffed by people around the state who are joining in to help us teach this. And then we spend about half an hour on topical presentations that are moderated by people who are doing that work. So you can see the list here of the presentations. We're almost done with our first year of this webinar. That was 22 hospitals have participated, and wave 2 was just kicking off as the COVID crisis started. So that's been delayed, but we're excited to get it going. We have the same people signed up to do all the teaching, and it's really been very powerful and motivating, I think, for the hospitals who called in on the first round. We look forward to the next. Next, please. We do have these biannual perinatal opioid project summits. They last all day. We do them out in Central Mass and have great keynote speakers, literature updates. We, in the afternoons, are a number of breakout sessions determined by the leadership group listening to our participating hospitals. Once a year, we do poster presentations and give awards for that. We have had real growth in this. We have over 400 people. We have people waiting to get in. So we've been really happy with the response around the state to this process. And lots of groups come and set up their tables, and it's just so much information is disseminated and collaboration occurs just on those 2 days. And then that holds for the rest of the year. Next, please. We have, like I said, we don't ourselves generate maybe as much information as some of our quality collaboratives. It's just the way we work. But we're really lucky to have lots of great groups in the state. And one of the things we really recognized was the importance of trauma-informed care and approaching stigma and bias as we've done this work around opiate use disorder and substance use disorder in general. We've teamed up with the Coordinated Approach to Resiliency and Empowerment Care Clinic, which is a Robert Wood Johnson funded group at the Brigham and Women's Hospital. And with them, we've helped augment and work on their presentation to think about trauma-informed care and how it affects care of women with opiate use disorder. We've, again, this got pushed a little off track by the present pandemic. We have actually hospitals signed up. We're going to be starting the presentations in the next couple of weeks. We have 22 hospitals that we will be working with, and we're going to be expanding that, we expect. Next, please. Population, we also have teamed up with MASPERT, which is the Massachusetts expert team. They have been doing this work for a long time, but bringing them in and collaborating with them and talking about QI process, how we measure our change, how we do PDSA cycles, I think has helped both them, and it's of course helped us a lot in having an amazing group of people to help our hospitals learn how to do appropriate screening, brief intervention, and referral to treatment, really thinking about how we link to care as well. Next, please. So we have also teamed up with the outpatient-based addiction treatment crew at the here in Massachusetts. They have been doing waiver trainings for all sorts of providers around the state, and we teamed up with them to get presentations specifically towards pregnancy and for obstetric providers, and we've had 2 of those happen already. We have a third. We've trained 27 providers through those. The next one is actually very highly prescribed, and I think the online aspect of this next one is really a draw for folks. And those are the 3 we have scheduled. We have more likely coming. Next, please. MCPAP for Moms is a group who started to help with psychiatric consultation in the pediatric space. They moved into maternal space a number of years ago. And then, of course, with the psychiatric illness associated with substance use disorder, they have now gotten funding for substance use disorder and have provided amazing service, not only doing immediate counseling and conversation with providers to help with patients with comorbidities of opiate use disorder and other disease, but also to help with linkage of care throughout the state. So they've been a real resource in helping advertise and bring their services to folks around the state. Has been a real plus for our caregivers and patients. Next, please. We've also collaborated with the Early Headstart team. They really have taken on what we're doing in pregnancy, helped set the stage for success for these families, and provided a lot of interesting insight into the work we're doing, particularly in the postpartum setting. Next, please. We've had a really great experience working with the BU School of Public Health. We've had 2 groups of students in their implementation class work with us on 2 different projects so far. We just thought it was a great way to help them learn about what we do in the quality collaborative space and around opiate use disorder. And also, we thought it would be a great chance to have an evaluation of one of our larger services, the RESPECT program at Boston Medical Center, use that information to inform others about around the state about what they might be thinking about. So we had 2 groups. One was working on stigma and bias, really great work around stakeholder interviews, environmental scan, literature reviews. They talked to folks. They really gave us a nice report on our services. And then we've reported that out to all the other care sites in the state so that they can learn what we did. Next, please. Also, they have we had one project on the pregnant women of color, project within Project RESPECT. Again, looking at a large substance use disorder in pregnancy treatment project and how we can really get those services equitably into our community. Next, please. Talking about physical environment. Next, please. And then internal outreach, and just the way that we present ourselves, I think is really important to reach out to the community, to improve our care, to bring our care to the right spaces, and ask people to come in. So we really have appreciated this work with the BU School of Public Health, and we're going to keep doing this and hopefully extend this type of intervention and help to other hospitals within our state through the collaborative mechanisms. Next, please. So thank you so much. You know, we've been doing this for a while. We have 3,600 babies now in our registry that we've been following over the last about 3 years, 4 years, and we just keep learning, and we really love what we do, and we love all the organizations we work with, and all of our teams. So I'm happy to answer questions. Feel free to reach me anytime to learn more, and check out our website. Thank you so much.
Thank you very much. Now I'd like to welcome our next speaker, Dr. Ann Borders, the Executive Director of the Illinois Perinatal Quality Collaborative and Clinical Associate Professor of Obstetrics and Gynecology at the University of Chicago, Pritzker School of Medicine. Ann will be sharing the experience of Illinois Collaborative in addressing opioid use disorder. Please go ahead, Ann.
Hi, everybody. It's really great to be joining you from Illinois today. We are excited to share our experiences and what we've learned, going through this process with Illinois hospitals. And I would just say, as you're trying to learn from the experiences in Massachusetts and Illinois, as we started this process, we did the exact same thing. We really cast a wide net to better understand how do we do this work and do it effectively? How do we really help our hospitals put in system changes and culture change, really move the clinical needle to really provide optimal care for women with opiate use disorder and their newborns. So if you can move ahead. I'm going to try to go through this quickly so I can get you guys the full scope of what we've done and hopefully get some data, but as I promised, I'll watch the time. So just a quick overview of what ILTQC is. I know some of you are very familiar with perinatal quality collaboratives. We are we work with almost every hospital in the state. We have 119 hospitals, which is over 99% of Illinois births. And we really work together to implement evidence-based practices using QI science, collaborative learning, and rapid response data. So we are a collaborative of hospitals led by providers and nurses and partnerships with public health and with patients and families and other stakeholders around Illinois. Next slide. And this is what our infrastructure looks like, so folks can begin to understand. We meet regularly with a leadership committee of MCH leaders from state agencies and others around the state. We have an OB advisory group and a neonatal advisory group that meets monthly, and that's made up of providers and nurses and public health folks from all over Illinois, and they really help drive and think about, and also patients and families. They really help think about our initiatives and kind of everything we're doing. We run through those advisory groups, which is really helpful to understand what's happening on the ground. So our hospitals themselves can really be helping to make the decisions of what they want to do next. And so this is really driven by hospital teams thinking through how to do this work together. And then of course our obstetric teams and our neonatal teams, which really make up the collaborative. ILPQC Central, that's neonatal leads, obstetric leads, myself, and nurse quality manager and nurse, our coordinator, and our overall state project director. Next slide. I want to just briefly help folks understand how AIM, maternal mortality review committees, and PQCs work together. If you can click ahead, there you go, click, and one more click. So what's back one? So I think it's really helpful. We've been talking about AIM this morning. We haven't brought up maternal mortality review committees, but really I think of these three organizations as really striving to work on maternal morbidity mortality at the population level, with MMRCs identifying issues and priorities, AIM creating bundles, these action bundles that Mishka first brought up and Ron discussed as well, that really create a bundle of resources and strategies that hospitals can implement to really think about how bringing evidence-based practices and reducing variation across hospitals. And then PQCs, of course, are being developed in every state, and they're really the glue that brings hospitals together to work on initiatives collaboratively so that we can really move the needle together. We're much more efficient and much more effective when we work together. So it's really about bringing hospitals together, utilizing data to make things better. Move next slide. We think of these three pillars as what makes the PQC happen, which is really providing opportunities for collaborative learning. That's where you're getting hospitals together to learn from each other, share barriers, share strategies for success. We use a lot of data. It's really important to our teams. They collect monthly data on every single one of our initiatives, both on structure measures and process and outcome measures. And they see that as their data. We're just a system that creates nice, easy to use data reports that pull immediately into their systems. And they use that data to drive their quality improvement. And then, of course, we provide a lot of quality improvement support to our teams, really helping them to understand how to do this work. And we try not to let any hospital fall behind. So we're doing a lot of one-on-one support to teams if their data shows that they're lagging behind other teams. And we use, of course, the model for improvement. Next slide. So our quality improvement strategy, when we're thinking about building an initiative, I would say engage statewide stakeholders, which you guys are doing. And we, of course, have this OB advisory work group, so we can really understand how this affects providers and nurses on the ground. We facilitate the development of multidisciplinary hospital-based QI teams, and we do this in almost every hospital across the state. And then we do this monthly collaborative learning webinars, and this is what Ron was alluding to as well. Those monthly webinars are really important to build the fiber of the collaborative. Hospitals share team talks at each of those monthly webinars, and we really start to learn from each other. And then we meet in person twice a year for face-to-face meetings where we do a lot of small group discussion, learning, poster presentations, et cetera. Next slide. When we're teaching hospital teams how to do this work, and I'm taking a minute to do this before I get to OUD, because I think it's really important to understand how this work gets done. So it's, building a QI team, assessing baseline data, plan where you're going to go. So we ask every team to do a 30, 60, 90-day plan, ask them to do small tests of change, and then collect data. That monthly data collection is one of the most important things that happens, because that's what drives their ability to understand if they're making change happen. And then we do a lot of reviewing and sharing data and helping them understand where they are in the process. And we do a lot of learning from other teams. Next slide. This is our data system. We start with the data reports that our teams usually work together to build to make sure that the data reflects what they want to collect and what they think is going to be helpful to them to drive quality improvement. They enter it into our REDCap system, and as soon as they enter data, they immediately get a report back. This is live reporting. So they put it in, and the report pops up that shows how they're comparing across time and then how they compare to other hospitals. Next slide. We do a lot of encouraging our teams in order to make this work happen. I think one of the places people get stuck is that they put system changes in place. So, you know, they'll put in a new screening tool or something, but unless they're actually getting buy-in from the OB providers and nurses to actually change the way they're providing clinical care, we're not going to optimize care for moms with opioid use disorder. So we do both systems change, and that's helping people get the things right, putting in protocols, checklists, order sets, debrief, but then they really need that culture change. We have to engage our providers and nursing with education and also feedback. And we do a lot of monthly review and use of that data, and that's where that feedback really helps to make sure that we're showing that we're actually changing how physicians and nurses care for patients, really moving that clinical culture change, not just putting systems changes in place. Next slide. So we work hard to say that we're leaving no hospital behind, and I mentioned this before, and that's where this QI support happens. And this is really the role of ILPQC, looking at data and making sure that all of our hospitals are improving together. Next slide. We also motivate teams to make culture and systems changes by awarding teams awards as they improve and as they cross the finish line to achieve the initiative aims. Next slide. Okay, let's go into a little bit about, I'm gonna go a little bit more into the weeds on the M&O initiative so that you guys can better understand how we do this work. And I wanna be able to really describe the tools and resources that we've utilized to help hospitals in Illinois improve. So I will go through some of it a little quickly, but it gives you a sense of the different tools and resources that we've provided and how we've structured our initiative to, we think, really help teams think about this thoughtfully and actually really think how we can optimize care for women with OUD. Next slide. I think a really important part of framing this work, when we started thinking about this work early on, this work was really framed in terms of the newborn. People talked a lot about NAS, and moms were kind of tacked on as an afterthought. The old way of thinking was really, we need to be screening on labor and delivery so that we can identify babies at risk and get those babies the care that they need. And that old way of thinking is pretty pervasive in hospitals, certainly was across our state. And we really had to change it to think about the lens of the mom and really think about this from a maternal mortality and a severe maternal morbidity issue, that we're moving to help moms with a chronic life-threatening illness, move them on the road to recovery. We talk about that road to recovery like Mishka was talking about this morning, on a journey, but really we're talking about how do we take women who are really at risk of a life-threatening illness. This data in Illinois was really helpful to demonstrate this to our OB providers, that opioid overdose is now the leading cause of maternal death in Illinois, and that our pregnancy-associated deaths due to opioid use disorder have increased by tenfold just between 2008 and 2017. So we went, you know, I'm on the Maternal Mortality Review Committee, and so I review these deaths. In 2016, we had 10 maternal deaths related to opioids, and in 2017, 20 maternal deaths related to opioids. And that compared to postpartum hemorrhage, we had 6, and hypertension, we had 6. So it really was eye-opening to really be able to say, OB providers, this is an urgent obstetric issue. We all need to pay attention to this, and we need to do something, and we need to focus on mom. And that was a real shift in thinking. I think as folks start to think about this work, they have to be aware that they're going to be encountering many groups who are still thinking about this primarily through a baby lens, primarily through an NAS lens. And we really have to move upstream and start thinking about how do we identify moms and really think about how do we move them to recovery to reduce risk of maternal death and overdose and improve pregnancy outcomes. Next slide. So we launched the M&O initiative in May of 2018. We had 107 hospitals at our kickoff, 101 OB hospitals and 88 neonatal hospitals. So a lot of folks. Our initial aim was really focused big picture on how do we improve the number of women who are receiving MAT and connected to recovery treatment services prenatally or by delivery discharge. And then we had a set of goals as well. looking at screening mom, and then optimizing care. So we started with our in-person kickoff meeting. We provided a toolkit to all of our teams and a data report system where they could submit monthly data. Next slide. These are our overall aims, what we felt we needed to do to achieve, to save lives. And again, we're really focused on that, saving women's lives. So on the universal validated OUD screening, our goal is to have over 80% of pregnant women screened with a validated screening tool. So we started with data collection, doing a random sample of charts on labor and delivery. Every hospital in Illinois collected 10 charts per month, and then looked to see whether a woman had a validated screening tool prenatally and at her delivery admission, just those two issues. We did the random sample so that we could really get a sense of screening for all women, not just women with OUD, of course. So that was an important goal. Can we identify women with opioid use disorder early in pregnancy and really think about implementing this idea of a universal validated screening tool? We also had the goal of MAT, recovery treatment, and then our clinical care checklist. And specifically in that clinical care checklist, can we make sure that Narcan, naloxone is being counseled and provided, and that hepatitis C is being screened? And then on the right-hand side, patient education. This is making sure that moms receive counseling and materials on OUD and NAS, and particularly focus on engaging moms in eat, sleep, console, and other non-pharm treatments, really trying to empower moms to be engaged in that newborn care. So these were the aims that we set out at the beginning of the initiative, and I'm going to walk you through how we did this. Next slide. So these are our key strategies. When I talk about system changes, this is what this is focused on. This is what we're asking hospital teams to put in place. So, you know, working on getting your validated screening tools on labor and delivery in your affiliated prenatal settings, getting a standard expert protocol. We use a clinical algorithm that I'll show you guys. Getting a mapping tool, so helping all the teams figure out what their local resources are for their teams to be able to link women to MAT and recovery treatment services. Implementing a standard OUD clinical care checklist, because again, OB providers haven't done this work often in the past. They feel uncomfortable with it. They're not sure what to do when they are faced with a woman with OUD, or they may just not see women with OUD very often. So really putting those tools in place became really important. Standardizing patient education on OUD NAS, completing provider and nursing training, particularly on stigma and bias, but also really understanding the clinical care needed to optimize care for these moms. And then finally, implementing missed opportunity reviews or case debriefs. So we asked our teams to review all OUD cases every month and look at missed opportunities to provide optimal care and provide feedback to their nurses and providers about where those missed opportunities were. Again, really trying to change that culture change. So these are the strategies our QI teams are putting in place. Next slide. And this is what we're asking OB providers to do. So this is the clinical culture change. If the slide before is what your QI team is doing, the system changes, this next slide is the most important thing, because those system changes are only being put in place to try to get this work to happen, which is getting OB providers and nurses, making it easy for them to do the right thing and provide optimal care. So this is the most important thing. Screening every pregnant woman with OUD with a validated screening tool, assessing for readiness for MAT, starting MAT and linking to recovery treatment programs, providing naloxone and Narcan counseling, prescription screen for Hep C, warm handoffs and close follow-up, and then patient education on OUD, NAS, and then of course reducing stigma and promoting empathy across your clinical team. So this, I think between these two slides are probably the two most important things I can show you. What are our QI teams trying to do to make it easy to make this slide happen? Next slide. In order to make that slide happen, we realized that we really had to shift attitudes and understanding about OUD. So this is also a really important slide, because you have to realize that your providers and your nurses have a very skewed understanding of opioid use disorder. So really moving them to these key messages. And we said these key messages over and over again. And we even made posters about these key messages and magnets and stuck them up all over labor and deliveries in Illinois. So opioid use disorder is an urgent obstetric issue. Opioid use disorder is a life-threatening chronic disease with life-saving treatment available. Reducing stigma improves outcomes. Key steps that OB providers need to take prenatally and on L&D to care for women, and that linking moms to MAT recovery services reduces overdose deaths for moms, improves pregnancy outcomes, and increases the number of women who can parent their baby. That was a really important message, because we had many providers and nurses who did not understand why we were trying to link moms to MAT and recovery services, and they had a hard time grasping what the goals were. And so this was our way of really making it very clear what we're trying to accomplish as we try to move women on the road to recovery. Next slide. These are our key steps. I'm not going to go through them, but we put these protocols up all over. And again, this is what we're asking our teams to do, figure out how to activate this OUD protocol for every screen positive mom. So screen and document positive results, provide that expert risk assessment and assess readiness to start treatment, activate care coordination and navigation, insert and complete OUD clinical care checklists, and then provide patient education on OUD and NAS. Next slide. So these are some of our screening tools. These were the screening tool options we provided our teams in Illinois, just to make it really easy for teams to choose one of these validated screening tools. So we use the NIDA Quick Screen, the 5P screening tool, and the Institute for Health and Recovery integrated screening tool. I would say our hospitals primarily used 5Ps and the Institute for Health and Recovery integrated tool, which has the 5Ps embedded in it. It's on the lower right side, and I think our teams liked it because it tells you what to do when you get yes answers. So they felt that was really easy for teams to follow, kind of next steps once they did the validated screening tool. Next slide. Another big issue for us was expert. I felt like it was overwhelming for our providers. Once we started saying expert, they would say, this isn't something I was trained on in medical school. I'm sure this is something we're supposed to call an addiction medicine doctor to do or a social worker to do. So we really had to change thinking around that this is just a doctor, this is about a provider walking in to talk to a patient about a positive screening result. And so it's really about how do you walk in, talk to the patient, assess their OUD diagnosis, counsel on risk, review their patient goals for the pregnancy, and assess readiness to start treatment, just if you got a positive screen for depression. And so really, really moving OB providers to feel comfortable walking in and talking to patients about that positive result and assessing their readiness to start MAT and linking them to recovery treatment services. We utilize these expert pocket cards, which we printed out, laminated, and gave to every hospital in Illinois. So a lot of providers were using those in the clinic to start. This is our next slide. We also realized that our OB providers, even after we did all that work, we had a series in-person meeting where people brought their workflow, and still people were not engaging their OB providers. They had lots of workflows where they still would screen someone positive, call social work, call neonatology, and they would just forget that this is a clinical situation. The OB provider needs to engage and treat a mom who's at high risk of maternal death. And so we really brought this algorithm in place in order to bring the OB provider and say, this is what you need to do. So I'm not going to go through all of this, but I think it really helped us to say, OB provider, go see the patient, assess them for MAT, and that's what the left-hand side is. Start the OUD clinical care checklist, that's what the right-hand side is, and then how to document in the middle. And so we really pushed this, just like we did with the hypertension algorithm, to say, this is what we need our OB providers to do. Next slide. This is our clinical care checklist. Again, we have OB providers and nurses who may not see patients with OUD very often. It's really helpful to know exactly what clinical steps are needed in order to provide optimal care. Next step. One thing we found is that even after having this algorithm and having this checklist, we still had OB providers feel unprepared. They didn't know where the algorithm was. Where is that checklist? I'm seeing a patient with OUD once every few months. And so one of the breakthroughs that we had was developing these M&O folders. We've now have M&O folders probably almost in every birthing hospital in Illinois. And it's a way to have the information you need at your fingertips when a patient with OUD comes in. So they've created these M&O folders and they've placed them in prenatal clinical sites so that when a woman screens positive for OUD, someone goes and grabs the M&O folder, and they're on labor and delivery, someone goes and grabs the M&O folder. It would make sense to have all these things electronically, but what happens in reality is that when it's somewhere electronically, that OB provider is not going to remember where that is. But if a nurse goes and grabs the M&O folder and brings it in and hands the provider the algorithm and the checklist and says, this is your responsibility, you need to do this. On the left-hand side are all the patient education materials. Again, they're right there. No one needs to go find them. And the nurse can go through those education materials with the mom. We made these education materials with patients using a series of focus groups. And on the right-hand side, you've got the information for the MSN, for the OB, and then you have a nursing workflow as well. The other big issue we came across was that our providers were not providing Narcan or naloxone. They felt really overwhelmed by it. And so we needed materials that could really easily help them know how to counsel, how to prescribe, and then what to give to a mom so that she knows what to do. So we included this quick start guide and a Stable Life, which shows how a provider counsels and prescribes. Next slide. So I'm going to go through the rest of these kind of quickly so you guys can just see the tools. This is our nursing workflow. We realized we needed something to help nurses know what their responsibilities were. So the left-hand side is the tasks on labor and delivery, and the right-hand side is the postpartum or delivery discharge nurse task. And this was really helpful. We just realized nurses had felt like they were kind of left out of this and didn't have a good sense of what their job was in relationship to moms with OUD, particularly who came through labor and delivery. And so this nursing workflow was really well received. Next slide. This is the issues with counseling and prescribing naloxone, Narcan. These are the two documents. The Quick Start Guide, many of you may have seen. The Stable Life is the document we produced, which is really about how do you provide and how do you prescribe it. And there's actually a QR code where you can get a sample script. We found many providers just had no idea what Narcan naloxone was. They were scared to prescribe it. Some of them thought it was MAT, and they didn't know how to prescribe it. They didn't know how to talk about it. So this Stable Life form was really helpful to us. Next slide. Our patient education resources that are in the M&O folder on the right-hand side, you can find them on our website. And it's really about empowering moms and helping them to understand what's important. I just had a little win. Last week, I was seeing a patient for a consult. She'd been seen in a private office clinic, and she came holding that upper right piece of paper. And she'd been given that by a doctor who saw her and screened her with a validated screening tool. And she came into my office saying, I think I need to get started on buprenorphine. That was the first thing she told me. And she was showing me this piece of education piece. So I thought that was a real win for me, at least personally. Next slide. This is our OB provider and nursing education campaign. And we made these posters. Again, we are really just trying to break through to OB providers that it's a leading cause of maternal death. We need to start MAT, link to recovery treatment, and provide naloxone. And we just kept saying those things over and over again until these posters were born. We also have some e-modules, particularly focused on stigma, which is one of the major issues you really have to start with when we're thinking about how to get OB providers and nurses to really engage in this work. We have a simulation guide, which our teams have used. And then we do a lot of grand rounds and OB provider meetings to come out and talk one-on-one with teams. We actually have a speakers bureau of OB providers around the state willing to give these grand rounds. Next slide. These are just examples of the posters. Next slide. More posters. Next slide. Make sure to think about stigma and bias. I've already talked about this old way of thinking, new way of thinking. We're really trying to identify moms with OUD early and connect them to treatment and recovery resources to put them in the position to be best able to care for their babies. I really want to help you think about the fact that that issue, old way of thinking versus new way of thinking, is really critical to understand that that's where many of your providers and nurses are still in the old way of thinking when you start talking about this. So when you start talking about screening, they think that you're talking about screening to identify babies at risk. And you really have to move them to talk about identifying moms at risk, linking them to MAT, recovery treatment, and getting them Narcan. Next slide. This is the monthly case review I talked about. So this is our M&O missed opportunity form. I'm not going to go through it in detail, but it's available on our website. And again, it's just getting that focus on OB providers and nurses. How do we provide optimal care for every mom with OUD? We talk a lot with some of our smaller community hospitals. You may have 1 or 2 patients with OUD come through your hospital this month or next month, or but that could be that one patient that either becomes another maternal death statistic, or you provide optimal care and get this mom on the road to recovery and prevent a maternal death. And so helping providers understand and nurses what the optimal care is, and going back and reviewing cases and making sure. We now have some teams who were doing case reviews monthly and decided we're going to do these case reviews while the mom is here admitted, and they've moved them to huddles so they can huddle and review the mom's care while she's in the hospital so that they can make sure everything happens before delivery discharge, rather than waiting to follow up post-discharge. Next slide. These are our 4 key strategies for success. As we move towards year 2 of this initiative, it became really clear that in order to get clinical culture change with our teams, we had to get them focused on these 4 strategies: implemented validated screening tools in prenatal and labor and delivery, getting these M&O OB folders so that you have the algorithm, the checklist, the patient education in the providers and nurses' hands, doing an OB and nursing provider education campaign so you really can make sure people really understand why this work's so important, and then doing those missed opportunity case reviews to make sure we're providing optimal care. Next slide. We have two helplines in Illinois. You may have similar in Maryland. One is to find local treatment resources, and that's open 24 hours a day. And then we opened this warm line, which is similar to what Mishka was talking about in San Francisco. It's available for a free addiction medicine consult service for OB providers. Next slide. I'm not going to go through these key points other than to say drug overdose is the #1 cause of maternal death in Illinois, and that we know linking to MAT and recovery treatment save lives. And we really have to convince our providers and nurses that there are these key steps and help make it easier for them to provide optimal care. Those are kind of the key messages I want to leave you with. And then very briefly, if I have a minute, I'd like to be able to show teams, I think what's important from the data, and I'll just nutshell it. We collected data on linking to MAT. Our team started out, only 40% of women receiving MAT during pregnancy or before delivery discharge. We're now up around 70%. The same for linkage to recovery treatment services, much lower than you would have thought. And the area that you'd be surprised, patients receiving education about OUD or NAS, very low when we started. Only 20 to 30% of moms were receiving information. And again, I think it's because of this idea that people just didn't talk to moms. I think they were really focused on the baby. And so we've really improved education of moms. And then the issue that's been our hardest nut to crack, which I really want you guys to focus on and think about, is Narcan naloxone prescribing. And we only started out, only 2 to 3% of pregnant women in Illinois were receiving a Narcan or naloxone prescription or had counseling on it during pregnancy or before delivery discharge. We're now up to 30% with an incredible amount of work, and that's the area we're really focusing on this year. Okay, thanks guys so much for letting us share the story in Illinois. I'm happy to talk about it more during the discussion time.
Thank you. Thank you very much, Anne. Now we'll get to hear about some of the work that Maryland hospitals have undertaken to improve maternal health care for women with opioid use disorder. Our first presenter is Kendra Ellison, the Director of Women's and Children's Services at Baltimore Washington Medical Center in Glen Burnie, Maryland. Kendra, please go ahead.
Good morning. Thank you for this opportunity to share with you the outstanding work that we're doing at University of Maryland, Baltimore Washington Medical Center regarding the care of moms and babies in the presence of OUD. Baltimore Washington is a part of 13 university hospitals. We are located in Glen Burnie, Maryland, and we are serving Anne Arundel County community. We are a 285-bed community hospital. We have a level 2 obstetric and neonatal program, and we deliver about 1,600 patients per year. We see patients from Baltimore Washington Women's Health Associate Practice Group, Chase Brexton, private community providers, and Kaiser Permanente. Like other areas in the country, we've seen a marked increase in the number of obstetric patients with opioid use disorder, and it's having an impact on both maternal and neonatal outcomes. So we've not been remiss from the opioid epidemic. Next slide. So in fiscal year 19, we recognized we had 62 substance-exposed newborns that we were dealing with some challenges throughout the year, and it had been a marked increase from the previous fiscal year. So we developed a multidisciplinary team consisting of the director, the managers of L&D and nursery, the midwives, OBs, pediatricians, social work, and several frontline staff. And we had two primary goals. With all of the energy and commitment in the room, we said, let's focus it on just two primary things that we really want to accomplish. And they were all excited. And we said, we're going to establish support and resources for women during their antepartum, intrapartum, and postpartum periods. And our focus is to reduce the length of stay and improve neonatal outcomes. Next slide. So like many process improvement projects, we began with staff education and training. We offered a series of in-services and skills day sessions. Our opioid education included core knowledge of opioids and the impact on mind and body, reviewing core understanding of substance abuse, addiction, and the impact on pregnancy and pregnancy outcomes. We reviewed the screening tools that were available and the documentation that would be required. Our skills day included simulations. We took a different approach. And this allowed the team to practice clinical interventions medically for respiratory depression. We practice withdrawal and preterm labor, and we allow for an interdisciplinary panel to discuss also lactation and the social services within the community that are available. The simulations also allow the team to practice effective communication with the patients and an opportunity to address personal biases and stigma that's associated with substance abuse. Our ongoing training efforts include mandatory MPEC, or Maryland Perinatal Education Consortium, as well as the Neonatal Education Consortium as well. And both of those programs allow the didactic education that goes with the high-risk pregnancies that we often see with opioid use disorder. Next slide. So we wanted to dissect and approach this based on the continuum of care, looking at the antepartum, intrapartum, and postpartum phases, seeking the opportunity to influence the outcomes of both moms and babies at each of those phases. So allow me to walk you through a couple of those interventions in those phases. Next slide. Starting with the antepartum phase, a period marked by early recognition and provider engagement. Patients were in prenatal care and they're attending their appointments, were being screened and often tested, and providers didn't have the access to resources or the office staff to help make the next connection for the patients in the community. So we established a full-time care manager, Tanisha Ellis, which is our social worker, who is dedicated to women and children's services, and she's based within the hospital, and she receives the referrals from the Baltimore Washington Women's Health Practice. They place the referral after positive toxicology in the prenatal appointment. She completes a full assessment of their living situations, employment. She assists with prepping the patient for hospitalization, advising them of testing and screening. She evaluates their parenting skills and educational needs, their mental health needs, social needs, family and father of the baby involvement. She identifies maybe their drug of choice, and also works with them if they are open to treatment. She'll provide them with the next level of resources and get the patient really enrolled into a treatment program. The care manager will then follow up throughout the pregnancy to see if they did get in the program, what their success have been, or downfalls or barriers. She also will take a moment to advise them about delivery and what to expect when it comes to the newborn admission, as oftentimes the parents aren't ready for their babies to stay in the hospital a little longer for treatment. So she'll also advise them of CPS referrals and any referrals to our Mount Washington Pediatric Rehab Center where the newborns will go for ongoing treatment. Next slide. So when our patients arrive during the intrapartum period, patients are admitted. We've revised our policy to require universal toxicology testing and use of the Headstart screening tool. BWMC began tox screening in 2013 on patients without prenatal care. And we quickly recognized that some babies were showing signs of withdrawal and we hadn't tested mom. So in 2014, we moved to toxicology testing of all patients admitted to the obstetric unit. We send urine on all newborns who moms tested positive. And then in 2019, we've added meconium testing to all newborns that are admitted to the special care nursery. Moms have a positive tox or a history of a positive tox. To support our clinical team, we have a strong social work and care manager support system. So in addition to Tanisha Ellis, who works antenatally and intrapartumly with our patients, we have Kurt S. Pert is our clinical director of addiction specialist. Keisha Jones is a nurse practitioner of addiction medicine, and Faith Davis is an addiction social worker. So through referrals and the Headstart screening, our specialists become involved in the patient's care. Kurt has been instrumental in collaborating with our OBs and midwives to prescribe medications when indicated. And if patients aren't in a treatment program, he'll do the consult, initiate the communication with our local health department, and also arrange for peer support for the patient. Next slide. So this is a quick screenshot of our EPIC documentation screening tool that the nursing staff will use on arrival or with admission. And we ask the key questions that are in the Headstart screening tool around drug and alcohol use. How many drinks have they had within the last 24 hours? Have have they utilized any substances in the last 12 months with their choice. And as you can see in the screen, it gives us a score, which we use the Audit C total score. And any score greater than 4 triggers an automatic referral for peer support personnel. And Kurt will be involved because he'll get the trigger electronically. Our social works gets a notification and trigger electronically when there's a positive toxicology screen. So we're using a little bit of our documentation system to support recognizing. Next slide. During the postpartum care phase, after we've identified some of the needs of the patients, when our peer supporters are involved, we get them up to the unit to meet with the patients during the postpartum window. Currently, our peer supports are resourced from our emergency department. As we identify their need, they partner with the maternal child health team. Our social workers also make the referrals to our local Department of Social Services and our Early Start program. They do the CPS referral. We also have a good connection with our ODSOS in the community. Our women-centered program that we utilize for pregnant women and also immediately postpartum, both inpatient and outpatient treatment, includes our CAT program, which is Centers for Addiction and Pregnancy, which is in the Baltimore area, the Chrysalis House, and Serenity Sisters. So we will make referrals directly to those community programs specific for our population. Next slide. So of course we have some patients that may decline the peer support, or they say they're not ready for treatment. And so this is the handout that we'll kind of give them, that will walk them step by step on how to access treatment on their own in the event they change their mind outside of our corridors. And it lists not just the local community for Anne Arundel County, but also a little bit in the Baltimore area. Next slide. So this is a checks and balances checklist that we've put into place for our teams, and it walks the staff through the labor and delivery, mother, baby, nursery expectations, reminding the staff to make sure that we put in the consults, that we do the screening, that we set up a family meeting so that we can get both the mom and the dad or their support system involved to understand the care the mom will need ongoing outside, the community access for resources, as well as the follow-up newborn. Next slide. We have also enrolled in a program that's around for Anne Arundel County, Harbor Hospital, and the Anne Arundel County Health Department. It's an MOU that we signed, and this is an opportunity for us to review all of the cases for our substance-exposed newborns, both multi-hospital, multidiscipline. We look at the resource allocation and the gaps that we may have missed along the way, and we hope to prevent future relapse and substance exposures to help reduce that length of stay for the newborn. Next slide. So, of course, some of the limitations that we are currently facing in our plan, of course, I had to put at the top is COVID-19, as it is truly forcing us to rethink about how the programs and the services that we set up with the impact from social distancing. We have the limitation that our social worker is only working with one particular physician practice, and how do we reach the other privates that deliver here? Our OB providers, not all of them have the waiver and certification to prescribe buprenorphine, so that's become a little bit of a limitation or barrier. The peer supporters, because they are utilized from the ED, they aren't maternal child health specific, so we're working on our next step for getting maternal child health designation, designated peer supporters. We've had a number of rapid new hires, changes in leadership, so trying to get the team refocused around OUD has been a little bit of a challenge at our organization. Next slide. So of course, are we there yet? When we looked at our two primary goals, I can honestly say, yes, we have increased the resources and access for our patients. We see a far increase in number of patients that are utilizing the community resources. The social worker demand is really high. And we see that evidenced by the reduced length of stay. Our newborns, without some of the families that are getting treatment, had an average length of stay of 10 days. And we're finding parents that are in treatment. We have a good diet, good use of resources. We've now reduced the length of stay for our newborns between 3 and 6 days. So I think we've set up a beginning of a process. It's a number of interventions that we'd like to revisit in the next fiscal year.
Thank you, Kendra. Next, I'd like to introduce Michelle Musgrave. Doctor of Nursing Practice and Director of Patient Care Services at Sinai Hospital of Baltimore. Please go ahead, Michelle.
Hi, good morning. Thank you all for the time, and I appreciate all the wonderful knowledge that has been shared currently, and I'm not sure how much more I'm going to be able to add to, but we'll talk a little bit about what we're doing here at Sinai. So Sinai is located in Baltimore City. We do about 2,000 births a year. We do also see our influx of substance abuse patients as well. Next slide. And we also have a level 3 nursery that we operate here. So we were fortunate enough to get a grant through the Mosaic group to implement the Headstart process, and we have our own peer recovery coach that is dedicated strictly to obstetrics. That is new. We've always had these peer recovery coaches in the emergency room, but about 3 or 4 months ago, we were able to have one dedicated specifically to obstetrics, and she has just been instrumental in helping our patients, helping us identify our patients, and then helping our patients get the care that they need. So we built our assessment tool into our electronic medical record, and whenever someone triggers a positive, either a positive drug screen or a history of substance abuse, an automatic referral is sent to the peer recovery coach and to our social worker, which is also dedicated to obstetrics. And typical of all, we screen all of our patients. And if they refuse to be screened, then we let them know that their baby will be automatically screened because of their refusal. So we spent lots of time, the Mosaic group leader and the peer recovery coach came in and did a multiple offering of education on how a nurse can screen, and then how they can do the whole discussion on the brief intervention, and just to help them understand how to have those conversations. We did some role playing, because as we all know, those conversations are very difficult to have with patients regarding their substance abuse. And as I said, we have a dedicated peer recovery coach. So next slide. So some of our structured processes are, we have a universal drug testing, and our infants are tested if the mother is positive or suggest history. Next slide. So here's where we also did some further education. So we've really worked hard on that. If a patient is in an MAT treatment, our providers verify the treatment and dosages and continue that treatment during the inpatient stay. What we have found is that once those addiction specialists find the patient to be pregnant, they kind of hesitate on then wanting to manage their substance abuse, because of the pregnancy kind of scares them off. So we've worked really close with our addiction medicine specialist, and we also have one of our providers that is certified to provide the medication. And she told me that what she normally does is she will prescribe just a couple of days dosage in order for them to bridge the gap until they can get back to their own treatment center. We also worked with our anesthesia team, physicians, to come up with the standardized order sets for medication during labor and C-sections, so that to minimize the opioid use. Next slide. So infant management. So we do, we use the NIS scale for those babies. We're looking at evidence-based practice for the appropriate scales for other substances to create maybe a more defined process of assessment and appropriate care. Comfort care, of course, cuddling, non-nutritive suction, we have low noise. So when any patient that needs medication, they get transferred up to the NICU for that regimen of medications. And then we also try, when babies have to stay and the moms are already discharged, that we want the moms to stay and provide that care for those babies, because they need to be with their mommy. So we try to provide boarding for those parents as much as we possibly can. Next slide. Oh, there we go.
Thank you, Michelle, and to all of our presenters. Now we have 10 minutes for questions. Please use the chat box to type your questions, and please indicate if a question is addressed to one of our individual speakers. So Dr. Katrina Mark is asking, who is entering the data into the QI databases for the states that are using these? So let me go ahead and give Anne and Ronald the microphone to answer.
Yeah, I can enter that. So our hospital teams, it's typically, so we have a QI team. It's usually a nurse leader who enters the data. I'm just going to show this really quickly to you guys while we're answering the question. So this is our structure measure data, and the data, they enter it as red if they haven't started working on something, yellow if they're working on it, and then green once they have it in place. And so these are those key structure measures that I told you guys about. What you can see is it really helps our teams see how they're moving across the initiative and how they compare to everyone else. So they're still on red and other teams are moving to green. It's a lot of momentum every month to really say, oh my gosh, we got to get our validated screening tool in place. So you can see we now have 97% of teams in Illinois have a validated screening tool in place on labor and delivery. We started out with only 2%. Most of them have it in place prenatally, for example, the Esprit algorithm, mapping tools. So our teams have really, really pushed on getting these system changes in place, and that's where this monthly data really helps. But it's usually a nurse who enters. We don't pay anyone, or it's just the hospitals feel that this data is really important for their own work. If you could skip down, I'm just going to show this real quick. I'm going to let Ron answer. Next slide. This is our data, the random sample of 10 charts per month at every Illinois hospital. We have about 16,000 women in this data set. We started out, almost no one was getting validated screening. The green is getting screened with a validated screening tool. The orange is screened with just a single question, like, are you using drugs, yes or no? And the red is no screening. What you can see is that prenatal screening really lags behind labor and delivery screening, which makes sense. Our teams were really able to enter the validated screening tools on labor and delivery really quickly, and then prenatally it's gone slower. But our teams are really good at entering this monthly data. Next slide. And now we have about 2,000 women with opioid use disorder, and this is women on MAT. You can go down. Just going to show us data. So this is women with OUD on MAT. You can see in Massachusetts, they started out about like at 80% and stay there. We had much lower rates of women on MAT in Illinois than they do in some of the some other states. And so we've really pushed with teams to try to get that MAT rate up, and that's why this monthly data is so helpful. And then I'll just go through the rest of them quickly. Next slide. This is getting people linked to recovery treatment services. Next slide. This is getting moms education. You can see very low rates of women being counseled about OUD and NAS. Isn't that shocking? Women were just not being counseled about these issues. When a social work consult really meant someone coming and talking to them about DCFS and what was going to happen to their baby, but they really weren't getting counseling about OUD and NAS and engaging in newborn care. Next slide. And then this is getting the checklist in the chart. Next slide. And this is that Narcan issue, which I told you has been really shocking, how few women OB providers are counseling and offering Narcan naloxone to. And this is a big issue for women having a risk reduction strategy. And the next slide is the Hep C screening. So I think that the data is really important for you to understand how you're making an impact at both the hospital and the state level. And really it's empowering those QI teams that this data is going to really help them with their QI efforts. They're not going to understand where they are. They may put some systems changes in place, but those system changes in place aren't going to mean anything if you're not providing optimal care for those patients. And that's where the data really helps teams, I think. And our teams are pretty motivated by that.
Thank you,
Yeah,
Anne.
this is Ron. Thanks, Anne. That's great. And yes, our information is all entered by the hospital teams as well, primarily out of the NICUs and the newborn nurseries. So it's all voluntary. they put it in on a red cap, we process the data and have it ready for them.
Okay.
And we have data entered both on the OB side that's really focused on mom, and then we have a whole newborn, part of this initiative that I didn't talk about today, but then our neonatal teams enter the data on opioid exposed newborns, and then we link those files on the ILPQC side we have the OB teams are putting in the mom data, and then the neonatal team is putting in the newborn data. Sometimes it's the same person depending on the size of the hospital.
Okay,
great.
Thanks. So Katrina Mark's asking, I'm trying to figure out how to avoid entering redundant data on moms that show up in several hospital triages.
So this is only data entered at delivery. So if mom showed up in multiple triages, this data wouldn't get entered on them. You would only have data this is data entered post-delivery. So all of this data is looking back to see whether mom was started on MAT or linked recovery treatment or provided naloxone during pregnancy or before delivery discharge. So we basically have that cutoff of, did this stuff happen before she was discharged from the hospital? Because it's such an important window for getting mom these treatment services before that postpartum period, which is incredibly high risk. And so we just use that delivery point as the marker. And the team that's pulling the data is looking back to say, did mom get linked to MAT, recovery treatment, get Narcan at any time during her pregnancy or during this delivery admission? So that's how we do it. So there wouldn't be any overlap.
We have a similar situation where it's always entered at the delivery site, and if there's any change in the baby's location, then it's the original delivery site that does the entry.
Thank you. So we have some questions in the Q&A box. Dr. Lorraine Milio is asking, how do you deal with patient fear of CPS involvement and potential to have infant removed even temporarily, to any of the speakers? I'll unmute Kendra and Michelle too, if you'd like to address that.
Really quickly on this, I think it's so important that we really try to educate providers, nurses, and patients that when we engage with these moms early and get them linked into treatment and services, we're actually helping the moms to get on this road to recovery to increase the chance that they can parent their baby. So everything we're doing, we're talking a lot about that helping moms get on the road to recovery is helping mom meet the goals of her pregnancy, improved health for mom, improved health for baby, and increasing the chance she can parent her baby. So I think that's why this new way of thinking is so important, is that our job is to get moms into recovery so that they can parent their baby. And if we can identify these moms earlier in the process and get them on MAT, it's going to really help. So try to move away from this, this idea that someone at labor and delivery is going to do a tox screen on you and take your baby away, versus coming into care and getting linked into recovery treatment is going to help you. One of my patients said, it's helping me build, my doctors and nurses are helping me build a resume of recovery. That's how she described it, and I just loved it. But it's about, she really felt that her prenatal care was helping her build a resume of recovery so that she could show that she was really best able to parent her baby. And I really love that phrase.
Yeah, we in Massachusetts have been working really hard on the plan of safe care and having a general form that then every institution is able to modify off of, so that they can use it in the prenatal sites as well, with the exact same idea that, really being proactive, preparing for success is key for these families.
Kendra or Michelle, do you have any points to add from your hospital's experience on that?
Yes, I would say our involvement with the social worker antenatally, working through the whole prenatal period, advising the parents, reduces that fear. It does put the resources in front of her so she doesn't feel that negative connotation that CPS has, and they actually begin to look at CPS as options for them, and actually partner with the social worker to get them involved. So I think just early intervention, early recognition, promoting it as a positive path to treatment recovery for the outcome for both of them, I think has definitely reduced some of that fear.
Yeah.
Thank you. So we have another question from Kelly Bauer for speakers from Massachusetts or Illinois. How specifically have your programs guided staff to respond to stigmatizing language or behavior from colleagues?
We
We've had-
have this word. Oh, go, Ron. You go first.
No, just that, we do bring that up at our, we brought that up on our webinars and at our semi-annual meetings to talk about what is stigmatizing language, how to avoid it, what words are appropriate, and also we've had full big conversations on trauma-informed care and stigma bias. So, we continue, we try to just weave that into everything that we're talking about. Go ahead, Ann.
Yeah, so I would say two things. We have an e-module called Words Matter, and if folks, our nurses and providers have liked it, it's short and but it has both a OB provider and also a patient talking. It was actually filmed at one of our annual conference, and it just, I think, really helps understand that patient perspective and why using empathy and building relationships and partnering with patients really does improve outcomes, and that stigmatizing language worsens outcomes. And so I think that just helping nurses and providers understand that the words that they choose to use and how they engage those patients is really going to matter whether these moms are successful or not. We have a language audit slide that we use as well that talks about, thinking about a language audit and words that you would choose instead of words that are more stigmatizing. So that's important. And then the other thing I recommend is really engaging patients. We have had a patient speaker at all of our in-person meetings, and it really is eye-opening for particularly our frontline nurses to hear these patients' experiences from their perspective. It's very humanizing, and the more we can do that, the better. And some of our hospitals, it's been so inspiring. We have teams of nurses from labor and delivery or for postpartum who've actually created a way to bring moms with OUD into the hospital and do tours with them early on and help them. And they say all the time, we want these moms to know that they have an advocate waiting for them at the hospital when they come to deliver, and that we're going to be a team surrounding them with support when they come in to deliver. And that's very different from coming into a place where you feel stigmatized and judged.
Okay, thank you. So we have a question from Bonnie DePietro. Ron and Ann, what great work. How are your PQCs funded to do this work? Are they independent organizations or part of a larger entity?
Ron, do you want to
go? So we basically run on grant funding that it goes to specific projects. Most of our funding right now is towards the opioid related projects. So we pay for basically small amounts just to pay for the co-chair time. And then also we have a couple project managers that are through grants, and then a small state fund state grant that we got. But we're always looking for more.
So this is Ann. So PQC funding is a big issue. We're always pushing nationally, and we're always trying to encourage Acog and SMFM and A1 and others to really lobby for us and our behalf as we think about how to, address the maternal child health crisis in Illinois, in the U.S. around disparities in outcomes, and really think about PQC's role in that and how we can get more sustainable federal funding and state funding. Right now, our funding comes from we sit outside. We're not in another organization, so we don't sit inside the Department of Public Health. Very specifically, we structured it that way. We can be a lot more nimble when we're not inside another organization. We can be pretty quick moving. And we also aren't seen as regulatory. Our OB providers and nurses and hospitals really see themselves as the collaborative, which is great because there's been a lot more transparency. We are funded from the Department of Public Health and DHS in Illinois, and then funds from the CDC, and then from some private organizations and foundations who are funding specific initiatives like Ron said. We spend a lot of effort and time putting our funding together, and it's always a patchwork, and we would love to have more sustainable state and federal funds, but that's just something that we have to all continue to push on. We do feel very lucky that we receive the state funding. The governor's office has made a real priority to make sure that ILPQC continues to stay well funded, and we have a legislative work group of state legislators who support us on both sides of the aisle. And so I think there's a lot of interest in making sure that ILPQC continues to be funded so that we can work closely with our Department of Public Health and Medicaid and our Department of Human Services. So I would say the big chunk of our funds come from those state state agencies.
I think we have time for 2 more questions to allow for a 5-minute break. So Andrea Krianga is saying, many thanks to all presenters. A question for all: how do you go about implementing the key OUD quality improvement strategies, as a bundle or one at a time based on local hospital context?
I would say that you have to, it's really important that hospitals, I don't know if you saw our key system strategies in the red, yellow, green. So we want our hospitals to be working on all of these strategies, but we want them to do it in a way that makes sense. And so that's why we put 30, 60, 90-day plans, and our teams kind of, we all started together, like our webinars kind of helped direct people as to what they wanted to start on. So most of our teams started working on screening and then getting their mapping done. Those were easy early wins. And then did, M&O folders and getting the algorithms and the clinical care checklist and the patient education into the hands of their providers, nurses, and patients. But if you just do one, because what I worry about is teams who just want to do screening, and they're going to be like, look, we just put screening in place, we're awesome. It's easy to do screening, you get it in an EMR and make sure everyone does it. It's much harder to do the clinical culture change where you really actually increase OB provider awareness and nursing awareness of this as a critical obstetric issue, and that they are the ones who need to assess readiness for MAT, linking to recovery treatment services and naloxone. And that linking to OB providers is the hard part. So I would say, as you're thinking about putting these systems changes in place, just make sure you're thinking about both systems changes and the clinical culture change. I will just really quick, we had, I had given a grand rounds at a community hospital, and a couple months later, the residents there somehow they had my cell phone, I'm not quite sure, but they called me one Friday night of a holiday weekend to say, you gave this grand rounds, Dr. Borders, and we have a patient here with OUD, and I remember there's something we were supposed to do before we sent her home, but I can't remember what it is. They had a patient there with OUD for 3 days. She'd had a social work consult. The social worker had just come in and talked to her about DCFS, never asked her about her own opiate use disorder or where she was in treatment or wanting to assess readiness for treatment. No OB and no neonatologist talked to her about those issues. I asked them to go read to me the social work consult and then pull up the clinical care checklist and algorithm off the website, go show it to their attending, and then go talk to the patient and call me back. They went in and pulled the clinical care checklist and algorithm, went through it with their OB attending, went in and talked to the patient. She wanted to start on MAT, was at rock bottom, was afraid to bring it up because she was worried it was going to make it worse for her with DCFS. They started her on methadone that night. They had kept her over the weekend to get her stabilized on a treatment dose. They got her into a recovery treatment program and discharged her there on Tuesday. They screened her for Hep C. She was positive, and they got her a Narcan prescription. So that's that idea of moving from just having system changes in place to really getting those OB providers to realize what they need to do for risk reduction strategies. So as you think about implementing these bundles, make sure you're thinking about both the system changes, but then how do you're putting those system changes in place in order to help your nurses and providers provide optimal care for these moms. So that's my soapbox about the bundle. It's important that we think about this as trying to get us to the point of providing optimal care.
Okay, and one last question from Linda Alexander. How would you recommend reaching out to OB practitioners that are not academics or not in large groups, like smaller solo practices? How do you build their buy-in to the process?
Ron, do you want to talk about that?
Yeah, that's a good point. And the hard part about a lot of this stuff, and you bring it out with that question, is that so much of the work we've been doing with the perinatal quality collaboratives is in hospital. And now that we've moved to the outpatient sites, it's a little bit tougher to reach folks. So we really have done sort of a spoken wheel idea here in Massachusetts, where we take the big institutions or hospitals and then have them reach out into their local communities. We've had a pretty good, actually, uptake from some of those smaller sites, even offices, calling in to our webinars, showing up at the big meetings, and trying to reach them through the process. What we try to tell people is, listen, it's QI process that matters if you want things to implement and then sustain. And we're a little bit less directive about which idea or project you're going to go to first. And Anne's right. Yeah, people think linearly, so they start with screening and how to get that going in their spaces. But I think that even a small site, an office, can take this on and try to measure it, make sure that what they're doing is actually happening, and then go on from there. So yeah, we sort of reach out through the hospitals out into the smaller sites.
We had we worked with our clinical teams at the hospitals to say, okay, guys, you're doing a great job on your labor and delivery and getting these changes in place. Now we need to help us. So you're gonna, we will help you reach out to your affiliated prenatal care sites. So they really went on, they did a great job. Our clinical teams at the hospitals basically set up strategies to reach out to all of their affiliated prenatal care sites. We put together packets, we called it prenatal site packets. And in the packet, it was like a flyer, a letter, and then we really asked them to do something very simple. We asked them to implement the validated screening tool and to have their M&O folder, a system for them to get their M&O folders. So we weren't asking them to do much, but we're really saying, can you get this validated screening in place in your office, and can you have an M&O folder there that your nurse can grab and hand this algorithm and checklist to you and the patient education resources. So when we were able to say, all you need to do is get the screening on board and get these M&O folders in place, that seemed like doable for our affiliated private offices. And they really got pushed to do that by the hospitals that they're affiliated with. And so it was the hospital team, QI team, that was kind of driving that work and reaching out to them. They really liked our posters and magnets that we put together for our OB education. And a lot of our teams sent these posters out to their affiliated prenatal clinics that say, do you know it's the leading cause of death? Have you assessed readiness? So it could really start to raise that awareness as well. So I would say that was that's how this happened. Like I said, that private office that sent me that patient and she somehow had this education piece, that's because that private office, someone had sent them, 5 M&O folders, and they were doing the screening and they had the M&O folders sitting there, even though I don't think they see very many patients with opioid use disorder.
Thank you again to all participants for the excellent presentations and questions. The slides and recordings of this webinar will be posted on the MD Mom program website as a resource for individuals and groups working on this topic. If you have any additional questions about the MD Mom program, please visit our website at mdmom.org or email us at contact@mdmom.org. Thank you for joining us and enjoy the rest of your day.